there is any fluctuation of jaundice. Any associated symptoms like pruritus, clay color stool, or patient having obstructive jaundice may have these symptoms. And if you have these symptoms positive, you can say at the end of your history that this patient is having obstructive jaundice. And other features like patient having a jaundice which is preceded by an attack of biliary colic, it may be likely a case of polydipolithiasis. Patient with jaundice, when there is waxing and waning, may have associated bleed, which may suggest a ampullary tumor. Bowel habit. When you are going to the bowel habit, it is important to know the exact history of the bowel habit. That means what is the bowel habit patient is having. That means frequency of bowel movement. You should try to find out what was the frequency of bowel movement when the illness started. Any change, whether patient needs to strain at stool, whether there is any sense of incomplete evacuation, any history of tenesmus, that means patient is going to the toilet number of times, is straining at stool, but no passage of stool. And then any bleeding per rectum. Another important abdominal complaint is swelling in the abdomen. Patient may volunteer that he notices swelling in the abdomen, and if the patient can appreciate the swelling, ask about where the swelling was noticed, the duration, size of the swelling if we can tell you, and then the progress of the swelling over this period of time. Then apart from this, we should ask about other urinary symptoms and other systemic symptoms, respiratory symptoms, cardiovascular, neural and muscular symptoms. So at the end of this, we should be going through the other usual history like a good past history, personal history, family history, treatment history, and any history of allergy. And when it comes to physical examination, the abdominal case, the first part is obviously general examination, and then you start with the local exams of the abdomen. And as you go, the local exam starts with inspection of the abdomen. How to do the inspection? You look at the abdomen from the side of the patient. You go to the foot end of the patient and inspect the abdomen. And we will be going through what are the things you look for inspection of the abdomen. You look for shape and contour of the abdomen. A normal abdomen is flat. That means if you draw a line from the distention junction, it will be going straight to symphysis pubis. Some abdomen may be bulging, which is called as distended abdomen. And if you have a patient who has got the abdomen is going back from the ziphied line, it can be called as a staphoid abdomen. Look at the umbilicus. Normal umbilicus is midway between the divisional junction and the symphysis pubis. This umbilicus may be displaced. Normal umbilicus is inverted. This umbilicus may get stressed or may become sometimes inverted. So, at the inspection, the next part in the examination is assess the movements of the abdomen. There are a number of things in the abdomen one should assess in the heading of abdomen movements. The first is movements with respiration. You sit at the bedside of the patient, ask the patient to take normal breathing, and normal abdominal movement, if there is respiration, you call that respiration is abdominothoracic. Next is look for peristaltic wave. How to look for peristaltic wave in the abdomen? Ask the patient to take a deep breath, ask the patient to expire and hold the breath at the end of expiration and look for peristaltic waves. So what you do is you ask the patient to take a deep breath and expire. You see, this patient has got peristaltic waves which are in the central abdomen, and this is moving one after the other. This is a classical step ladder pattern of peristaltic waves being seen in the abdomen. This is the patient of acute interstitial obstruction. So that is how you look for. You should sit by the side of the patient, ask the patient to take a deep breath at the end of expiration, and you look in the abdomen for about 1 to 2 minutes, and you look for the peristaltic waves. If the peristaltic waves are present, you describe the pattern of peristaltic wave. Here you can find the peristaltic wave in the central abdomen and moving from up and down like a step ladder. suggestive of small bowel, visible peristaltic waves. Then look for pulsatile movement in the abdomen. How do you look for pulsatile movement? You ask the patient to take a deep breath. She should expire and hold the breath at the expiration and look tangential. Patient may have a visible pulse in the epigastrium, which may be either a transmitted aortic pulsation or it can be an expansile aortic pulsation. Then, if there is a lump in the abdomen, we should some points about the lump of the abdomen. So the first point to decide in the lump is whether the lump is internal parietal. That you ascertain by rising test. You ask the patient to raise. You see the lump is, this patient has got a lump which becomes less prominent on head rising test. This can be also done by asking the patient to lift the leg and look at the lump. This lump becomes less prominent, suggesting this to be an intra-abdominal lump. Apart from this, we should describe the lump on inspection. The position and extent in the abdominal regions. Try to describe the shape and size of the lump. If possible, make out the surface as you see from the skin surface. And if the margins are well defined, whether you can see all the margins or in some cases you can see one or two margins and other margins are not clearly visible. A patient who has got a lump coming below the costal margin, he may not see the upper margin. A lump which is coming from the pelvis, he may not see the lower margin. Then one should assess the renal angle area. Ask the patient to sit. Ask the patient to sit and inspect the renal angle. The renal angle area is the area below the 12th rib at the abdominal spine. That is the area I am showing where one should inspect for any fullness. Then inspection of the inguinal area and inguinoscrotal area in male. Inspect the inguinoscrotal area for any swelling. Ask the patient to cough to look for any cough impulse there to assess any presence of hernia. So look at the inguinal area and ask the patient to cough. Look for any expansile impulse on cough. And then look for the external genital. In female patient, you inspect the vulva, the labia, major area. In male patient, we should inspect the scrotum, testis, and the penis. Then abdominal palpation is very important part of examination, and before you start examining the patient, you should have an idea about the different regions of the abdomen. Unless you have that area in your mind, you cannot make out where the lump is located, which area you are examining. So abdomen can either be divided into quadrants. That means you draw planes, a vertical plane to the umbilicus and horizontal umbilicus. This divides the abdomen into 4 quadrants. We call that as right upper quadrant, right lower quadrant, left upper quadrant, and left lower quadrant. So if you can describe the abdomen by either regions. This is just for demonstration. We should not do it in the examination. This is just for demonstration that we are dividing the abdomen into quadrants. The next is, we can divide the abdomen into regions as we do in standard anatomical division. So this is often a question examiner asks, how do you find the right hypochondriac region? How do you find the basic region? So you can divide the abdomen into regions. That is by, this is the method you draw the different planes. The first is transparently plane. You find the epicentral junction. Patient one hand breadth below the epicentral junction is the transparently plane. Once you draw this plane cuts at the tip of 9 costal either side. So this is the upper horizontal plane. Then you draw the transtubercular plane. You find the anterior spine, and from there you go laterally along the iliac crest and find the crest. You find these 2 points on either side, tubercle of the iliac crest, and draw the lower horizontal plane between the 2 tubercles. So this is known as transtubercular plane. So 2 horizontal plane, one transparentalic and one transtubercular plane. Then you draw two vertical planes, finding the mid-inguinal point. Mid-inguinal point is the point between the anterior spine and the symphysis pubis. So put that point on the groin. Find the mid-inguinal point. Midway between the anterior spine and symphysis pubis. And then draw a vertical plane from this point to go up and meet at the mid-clavicular point. So these are the two vertical planes we draw on either side. So this divides the abdomen into 9 regions. You will be finding that we described as hypochondriac area. Hypochondriac is a very small area, is a thumb size area in the abdomen, is largely covered by the costal margins. So by this 2 horizontal and 2 vertical planes, we divide the abdomen into 9 regions. Right hypochondriac, epigastrium, left hypochondriac, right lumbar, umbilical, left lumbar, right iliac fossa, hypogastrium, and the left iliac fossa. Then you start with the superficial palpation. What is superficial palpation? You just run your finger and do a mild dipping in the abdomen to assess some of the findings in abdomen examination. How to assess the temperature? You assess the temperature in the back of the fingers. So try to compare the temperature with the chest and go to each of the quadrants or regions as you like it. Either go by quadrants or go by regions and compare the chest temperature. So this is how you look for the abdominal temperature. Don't finish up in one point and say the abdominal temperature is normal. So you have to see all the regions or go to each of the quadrants. Then try to assess any superficial tender area in the abdomen. You just dip a little, don't dip too much. You just dip your finger in the abdomen and run your finger in the different regions to assess any superficial tender spots. Start in the left iliac fossa, then lumbar, and go to each of the regions and look at the patient's face to say whether this area is tender or not. So this is how you elicit superficial tenderness. Then we describe something called feel of the abdomen. When you dip the abdominal wall, you find the abdominal wall dips in. When you release, it comes back. This is a classic description of soft elastic feel of the abdomen. Sometimes some underlying pathology in the abdomen, patient may have a voluntary rigidity. That means you find resistance in yielding the abdomen. We call that as muscle guard. Or some cases of advanced peritonitis, you find that abdomen is boat-like, you cannot yield at all. So that is how you go. You just dip the abdomen at that point and feel. You see, this is easily going, and as I release, this come back. This is a classic soft elastic feel of the abdomen. Then any lump in the abdomen can be appreciated even on superficial palpation. So if a lump is palpable in the superficial palpation, you can appreciate the lump and you can take the liberty of describing the lump with the deep palpation. There is no point describing the whole lump in superficial and again deep palpation. So you can say the lump is palpable in the abdomen. This is being described in deep palpation. This patient has got a lump palpable in the right hypogonal lumbar area. She has got a classical gallbladder lump. So this is a lump I am palpating in this patient. So this will be done better in the deep palpation. Deep palpation is a classic description of finding different deep tender spots. But this appreciation of deep tender spots follows history. If the patient does not have any history of acute appendicitis, you need not say that McMahon's point is not tender, because our examination will be guided by the background of the history. So these are the different points. Just for decide how do you go to these different points. How do you find the McMahon's point? This is the point in the spine umbilical on the right side at the junction of medial two-third and lateral two-third. So that is the McManus point. What is the gastric point? You find the epigastric area. The central point in the epigastrium is the gastric point. Then gallbladder point. Gallbladder point is the area at the junction of rectus abdominis in the tip of the ninth costal. That is the transpleural pen cutting the costal margin. But once the gallbladder is palpable, you need not find the tendons the gallbladder point, because in that case gallbladder is already enlarged. So you can find the deep tender spots by looking at the different landmarks. Then next part of the palpation is the different organ palpation. So how do you palpate the liver? Patient is relaxed. You start palpating from the right leg fossa with the radial border of the index finger and gradually go up, ask the patient to get normal breathing. So once you find that you can palpate a swelling having a linear border, you confirm that this is likely to be liver and confirm that is a liver by palpating other points. That means it will be linear. You can palpate only the lower border. You go up, it is going deep margin. And if you have a patient, you can see this patient has a palpable liver, and from the lower of the liver there is another bulge which is seen moving up and down with the respiration. So that is the gallbladder in this patient. So that is a method for palpating the liver. How to palpate gallbladder is same like liver palpation. That means to palpate the gallbladder, if you examine how to palpate gallbladder, you start like liver. Start and go up. Once you find it being a liver border, in this patient has a lump which is having and in this patient the liver is also palpable. So you can find from the lower border of the liver there is a bulge, and this bulge is gallbladder. Why? Because you have a palpable medial border, you have palpable lateral border and the lower border. The upper border is continuing with the liver surface. So that is how you palpate the gallbladder. How to palpate the spleen? For palpation of the spleen, you keep the patient supine, keep one hand over the left side of the chest, and in the radial border start palpating the right leg fossa and go gradually towards the left hypochondriac region. So if the spleen is palpable, you can make out the margin against your radial border. Ask the patient to give normal breathing. Sometimes small splenomegaly cannot be appreciated in this manner. So in that case, ask the turn to the right side and palpate close to the costal margin at the height of inspiration. Or you can do it by hooking method. You hook your finger around the costal margin and ask the patient to take deep breaths. How to palpate kidneys? So palpation of kidney is classically described as a bimanual palpation. You keep your posterior hand. Why do you keep the posterior hand? This posterior hand is kept in the area between the lower border of the 12th reef and the iliac crest, and keep your anterior hand against the lumbar region and try to palpate the kidney bimanually. So keep your posterior hand and the anterior hand, and you should not keep your posterior hand over the iliac crest or over the above the ribs. The hand should be kept between the 12th reef and the upper border of the iliac crest. Apart from this, patient may have a lump palpable in the abdomen. So if the patient has got a lump palpable in the abdomen, the lump should be examined as you do any other swelling in the body. But in abdomen, we have a separate part to discuss. Is that first you decide whether the lump is parietal or intra-abdominal by rising test. And once you have found the lump, try to palpate the lump and delineate the borders. And once you delineate the border, you describe the lump shape and size surface and margin, then palpate and to appreciate the consistency, and then ask the patient to take deep breaths and appreciate whether the lung moves in the respiration or not. Then apart from this, one should palpate the hernial. On inspection, you said there is no swelling in the hernial sites. On palpation also, you keep your finger and ask the patient to cough and try to appreciate whether there is any palpable expansal impulsion cough in the groin area. Apart from this, one should examine the external genitalia, palpate the penis and palpate the testicle spermatic cord in male, and just inspect the area of the vulva. External genitalia. Then, how to do the percussion? The normal percussion of the abdomen is resonant. So, you start percussion of the abdomen from the epiphyseal junction, start percussion and go up to the symphysis, and then percuss on either side towards the flank. So, normal abdominal note is resonant. Another important part of percussion is to assess shifting dullness. This is gastric outlet obstruction may have a distended stomach, which can be demonstrated clinically. For this, you place the stethoscope bell in the epigastrium and start scratching the abdomen with a soft pain, costal margin, and you can delineate the greater curvature. So keep the stethoscope and keep on scratching. You can hear the creaking sound in the ear. So mark. Keep on marking. Normally, greater cavity of the stomach is above the umbilicus. So as you keep on scratching, you can appreciate the greater curvature. So this is a greater in this patient. So this clearly demonstrates that this patient has got a distended stomach. The greater curvature is running below the umbilicus. Parental examination is a part of clinical examination, and a postgraduate student is supposed to do the parental examination. And for this, we should take a consent, explaining the patient what is to be done. Ask the patient to turn on left lateral side with the upper right leg towards the abdomen and lower leg being straight. And before you put your finger into the anal canal, you inspect the anal canal area. In an abscess or acute fissure, one should not put your finger into the anal canal. So first, do a good inspection of the perianal area. Then to the digital examination, you lubricate your large finger and then place the finger horizontally. Don't put your finger directly into the anal canal. You lubricate the finger and keep the finger horizontally. Keep the finger horizontally and slide it towards the anal canal. Then do a methodical examination. First, appreciate the posterior wall of the anal canal, the rectum. Then turn your finger towards the lateral wall and then turn the finger anteriorly to feel the prostate in males, and you can appreciate the cervix in female. So apart from this, you should do a good explanation, and this should be done in brief. You should go to the other systemic symptoms, summarize the patient, and give a provisional diagnosis. Thank you.